Good afternoon, everyone. My name is Dax Corsi. I'm a third-year pediatrics resident in Halifax at Dalhousie, and I'm one of the co-leads for health workforce planning with the Canadian Health Workforce Network. And with me,
Sarah Simkin, we've met already, and we're really excited to tell you about a modern data architecture for workforce planning.
what if getting access to health data for planning was as easy as asking the question in an AI chat box? Health administrators may ask what the needs are for mental health in different areas of Nova Scotia, for example, in order to allocate funding as well as resources for a new care team. I personally would be curious to know what the forecasted needs in pediatric neurology are in 4 years down the line across the country. You ask the question, click generate, and you get the answer. You get the best available data pop up right in front of you. This is possible, and we're going to show you how. But the most important part of this presentation is that this is going to happen. Whether it is for profit or not is the real question. Our mission is to collaborate with stakeholders to empower and sustain public healthcare systems in Canada.
So, our health systems are currently experiencing unprecedented challenges. Some are saying it's a crisis. These challenges highlight an imperative. We need to plan. Health workforce planning can help ensure that patients receive the right health services from the right care providers at the right time and place. Planning allows us to develop, implement, and evaluate fit-for-purpose solutions to specific challenges so that we can respond to immediate health workforce crises and prevent future ones. And ultimately, planning will sustain our public health systems in Canada. And yet, health workforce planning is not an easy thing to do. The biggest barrier to planning is data. If decision makers had timely access to comprehensive, granular, standardized, and interoperable data, planning would be more feasible. This is possible. It's being done in other industries, and it's being done in other jurisdictions, and we can do it here in Canada. Today we're going to show you how. A modern data architecture for health workforce planning that responds to the planning imperative.
At its core, our health data architecture revolves around healthcare delivery. Here, patients need health services provided by healthcare providers, leading to outcomes. Each one of these steps leads to invaluable data comprising of 4 different streams: patient data, healthcare provider data, health services data, and outcomes data. And together, these streams form the foundation of our data-driven approach for comprehensive and effective health workforce planning. The raw data is then filtered and cleaned up through a data integration process prior to going through the pipeline and loaded into a pan-Canadian health data repository. This forms a centralized hub for health workforce planning that is interoperable with other health data pipelines. Here, advanced analytics, data intelligence, real-time data processing empowers decision makers with actionable insights in order to make decisions via user interface and dashboards. Ultimately, they have the evidence-based data to inform decisions to improve and sustain healthcare delivery. The next 3 slides, we're going to present you more details of this figure, and then after we'll show you how this applies to the unique Canadian context.
At the heart of our data architecture is the insight that we already have the information we need to plan. When a patient receives a service from a healthcare provider, data are generated. Capturing these interactions at every encounter in every region in Canada will allow us to understand who received what health service, from whom, where, when, how, and why, and what were the outcomes. So, 4 streams of data generated through healthcare delivery related to patients, providers, services, and outcomes funnel into a data integration process and then into the data pipeline for planning. You'll note that on this figure there are several enablers, denoted by a labeled circular icon. Enablers of efficient healthcare improve change management, data literacy, and performance management. Enablers stakeholder engagement enables the integration of other sources of health data into the data pipeline and ultimately into the body of evidence available to support decisions that improve and sustain healthcare. The next step in the process is data integration, which brings all these disparate data types and formats together.
The data integration process is complex, but without a doubt possible, with countless international success stories in health and beyond. This step is fundamental, especially in Canada, to make sure that the data that we use to inform decision is robust. This, in other words, is to avoid garbage in, garbage out. Many of you will recognize the extract, transform, and load, or ETL processes, which are common to data science. What we've done is apply this to health data. The entire process is accessed and managed by authorized parties. And in Canada, this may represent regulatory authorities or Indigenous affairs, for example. From the top, the raw data is then extracted by means of push, query, automated processes and data. And then all this is facilitated by application programming interfaces. From there, the data undergoes a transformation process where minimum data standards are key and critical. The reason is because they allow for specific data elements, unique identifiers, and use consistent data semantics. Then the data is converted to FHIR. FHIR is Fast Healthcare Interoperability Resource, and is the common gold standard internationally for health data interoperability. In the United States, FHIR is now mandatory for any electronic medical record, and Canada Health Infoway, Health Workforce Canada, and CAHSPR are leading visionary work as we speak to do the same in Canada. After this, the data is then linked in time and in place prior to being loaded into a FHIR server, and then from the FHIR server, it gets loaded onto the data pipeline for health workforce planning.
The next step is to harness the power of these data to inform planning and decision making. Following the data integration process, data flow through the pipeline into the secure Pan-Canadian Health Data Repository. This is where analysis happens, mediated by data intelligence and governance, and enabled by cloud storage. In this repository, data can be integrated with one another and with data from other pipelines. Data processing involves consolidating data and applying schemas and security measures to create fit-for-purpose data sets that can be queried to address planning questions. Real-time data processing, data linking in time, and health information exchange standards enable these connections, transformations, and analyses. These accessible health data are made available to decision makers through a data application for health workforce planning. Secure access, data download capabilities, and real-time data visualization and analytics enable decision makers to leverage data to support planning. Feeding back insights and intelligence from data collected through the delivery of healthcare services ultimately informs decisions that improve and sustain subsequent healthcare delivery.
This last figure takes a step back and really illustrates how this modern data architecture is made to support and to enhance existing provincial and territorial data processes, and also to alleviate the time and the cost burden of conducting health workforce planning. Authorized parties are at the core of operations. The key elements to this figure is that the data, once in the FHIR server, at the click of a button, can be loaded onto existing PT health data repository. And similarly, when the data loops back all around the pipeline, along with national aggregated data, it can be used for fit-for-purpose scenarios with the integrated data analytics that's provided, or authorized party can download the data into their provincial and territorial data repository to augment existing data processes. Shared storage, shared ETL tools, and shared processing power is included to ultimately improve and sustain healthcare delivery for every province and territory in Canada.
So let's recap. Data generated in the course of delivery of healthcare services are collected and fed through a data integration process that includes a modern data standard into a data pipeline for health workforce planning. The pipeline leads to the Pan-Canadian Health Data Repository, where data are integrated for planning purposes and are returned to decision makers through a data application. This is the technical solution to the planning imperative, but it will take more than a technical blueprint to actualize functional health workforce planning in Canada. The next steps are to address the human factors that influence the feasibility of this solution. These factors include technology, governance, legislation, culture, regulation, policy, data literacy, and communication. Our team is available to engage and collaborate with interested partners to work on these factors and take the next steps toward making this data architecture and better health workforce planning a reality.
So I think we're out of time, so we'll leave our key messages on the board, and thank you all very much for attending. And
Thank you. So we have some pro-qualitative messaging, we have some pro-quantitative messaging, fist fights in the hall afterwards. Et juste aussi pour rappeler, si vous voulez vous poser des questions dans la langue de votre choix, on serait prêt heureuse de traduire.
ça fait plaisir de répondre en français aussi.
I'm going to speak from here and hopefully I'm loud enough. You mentioned the garbage in, garbage out as being a problem that you're trying to avoid. When you're capturing data based on healthcare encounters, you are by definition missing out anybody who cannot encounter the healthcare system for whatever reason. Are there processes in place to avoid further marginalizing folks who are already marginalized because of the fact that they can't get to the healthcare system to begin with?
Yeah, that's a great question. So you're talking about how do we address unmet need in our plan, and clearly unmet need is important because this is based on the services actually received. It's not immediately captured, so we have to build in the process and make sure that those folks don't fall through the cracks. This is doable. We're doing it in Toronto, and it just takes a little bit of awareness that this is an issue and it can be integrated. I think it comes in the analysis and modeling part of it, less the data collection, pipelining, that kind of thing, but more in the what do we actually do with these data in order to support decision making? Let's recognize them and not miss something.
I totally agree. And to add things like this is the solution to show people what the needs are, and to actually get these unmet and unfilled needs on the map and given data and having support and having data to support and show what the needs are in those underserved areas.
Okay, can I use the mic? I think it's better with the mic, right? Well, thank you for this beautiful presentation. I don't know if beautiful is the right word because I'm not really good at vocabulary, but that's the one that I can find. Now, my question, you mentioned that, and by the way, thank you for the shout out to InfoWay. My name is Waldo Bosejo and I work for Canada Health InfoWay. You mentioned the human factor. There is a piece of work that was conducted by Ewan Affleck and his team in Alberta, and they mentioned that interoperability is not only a technical problem, it's a human. There's the human factor, and I'm glad you mentioned that. Now, the how we factor this into the equation. And when it comes to the provinces and territories, they have different healthcare systems, right? Now, how do you take this into consideration?
Great, so I can answer this first, and totally we're referencing to the Interoperability Saves Lives report by UNAF and mentioning the human and technical factors. Actually, that report was shared to me by Deborah Coleman, who's also in the room. So, which is a great report, and you know, I think we've heard this through the conference already so far. Collaboration with the different stakeholders and able to work together towards a cohesive goal is a great start in terms of connecting the technical factors with the human factors that together need to work in order to achieve results. There's a great framework called the LEADS framework, just in terms of leadership, that actually really fits well in this field and would be one for reference as well in terms of how to accomplish this. And then with your second question, which was, remind me again.
the differences across provinces and
Oh yeah, so totally, right? And this is why like this architecture is meant to support and really to augment whatever existing processes that are there. It is not meant to be directive, it is not meant to take over anything. And so really that's where there's some core kind of underlying support that meets each province where they're at in order to be able to best support them with the tools and with the processing power and the storage that they need to be able to effectuate health workforce planning essentially. So each province and territory will look different, and that's the whole point.
Sorry, I see a lot of hands, just in fairness to all the speakers, because some also we have to end on time. But we've tried to build in a few extra minutes for general discussion at the end. So without further ado, I will then ask for the next speaker, and hold on to your questions, please. Remember, fist fight in the corridors afterwards, quantitative versus qualitative. But without further ado,